This conference will now be recorded.
Perfect. All right, so we're going to talk about chapter 13, which is the vascular access and medication administration. So this is really going to focus on IV therapy, how we're going to access the vasculature, and really how we're going to administer meds. We have different abilities to administer medications, whether it be like intranasal versus intravenous, interosseous, intermuscular, sublingual, all the different ones, PO, things like that. So we're going to kind of cover all those different medication administration routes, access points, and excuse me, and whatnot. So obviously we have to meet the National AEMT education standards on pharmacology and how we apply that to the AEMT. The different routes of administration, self-administer medications, peer administer medications, and assist administer medications to a patient. You can find those all in your books with that. Just a kind of reminder, the next break that we have within the hour, we are going to be discussing who doesn't have their books yet, because you're going to need your access codes as they expire. The current ones that you have, if you haven't put new ones in yet, which means you will not have access to the AAOS platform. So I do have those access codes present with me. I can send you guys an email with that so you can log into it. We're going to cover the emergency medication names, effects, indications, routes, and dosages, as well as the actions, contraindications, complications, side effects, interactions. These are the things that you need to know about every medication that you administer to a patient as well. So we'll go over that stuff. So before you administer any medication to a patient, it's important to understand how the medication will affect the body. Remember I mentioned before, cause and effect, right? You have to understand what you're doing, why you're doing it, when it goes in, what do you expect to actually happen. This will include the mechanism of action. So what is going on in a pathophysiology, what is going on with that medication down to the cellular level. The indications being, when is it indicated for? Nitro being indicated for acute coronary syndrome, things like that. Contraindications, let's use nitro for an example. Mechanism of action of nitroglycerin would be like vasodilation. Within the vasculature, indication would be for the acute coronary syndrome and chest pain. Contraindication would be someone that has like an active bleed or stroke. Other ones would be like hypotension, things like that. Route of administration is going to be under the tongue, and I want you guys to use the medical terminology sublingual. The dose is going to be 0.4 milligrams per tablet. Adverse reactions obviously would be severe hypotension to the point where patients can actually go into cardiac arrest due to the low blood pressures. So those are more adverse reactions to that, or they can have an allergic reaction to that, or a hypersensitivity to the med. And then what to do in an event of an adverse reaction, how do we fix it? Obviously with fluid administration, like a fluid bolus, to bring that blood pressure back up again. So having the understanding of every medication you get, and for moving on from EMT to paramedic, the paramedic level is 110 different medications you have to memorize. So there's a ton of those. We're memorizing probably about 15 or so medications. And we also have to go back and memorize the EMT ones, not just the A drugs, but the EMT drugs as well. So the first rule of medicine is first, do no harm. All right, so ensure that a specific medication is clearly indicated to treat that patient's condition. It has to be meant for that patient. What you're going to treat for that specific condition, which is why it's so important before you administer medication to do an assessment. So as I said, the careful assessment of the patient will help ensure that only the beneficial medications are administered. So if I have a patient in anaphylaxis, I'm not going to give them nitroglycerin. It's not meant for that. I got to make sure I look at that and give the epi that they need. Intravenous therapy is one of the most invasive procedures an AEMT will learn. We're taking something and introducing it into their body system, a foreign body going in. So fewer procedures will require more training or practice. So we're going to have, like I said, IV arms on Sunday. We're going to be practicing intravenous access points. Proficiency in IV therapy and techniques are required for most advanced life support procedures that we do. 90% of the medications we administer will be given through intravenous medication, including Zofran, things like that that are not within the national scope, that are within the New Hampshire scope of practice. Medical problems alter the established balance among the systems of the body. We talked about that whole homeostasis thing, right? So we need to make sure that we're fully assessing the patient's condition, identifying life threats, and treating them, treating the illness and injuries that alter that homeostasis. And that could be the fact that they have an electrolyte imbalance to hypovolemia, whatever it may be, that can actually change the course of the homeostasis. And basic math skills are also required to calculate the appropriate medication dose. Everything that we do in a pediatric world is weight-based medications. So the adverse reactions, including death, may occur if you administer an inappropriate drug or dose, giving medication by the wrong route, like giving somebody epi 1 in 10,000 intravenous. I mean, sorry, not intravenous. 1 to 1,000 intravenous, not 1 to 10. Giving a medication too rapidly or too slowly can also cause a lot of damage as well. And we'll cover all those here in a little bit. Medical direction, as well, medication administration is governed by your local protocols and your online medical direction. So we have our standing orders, then we have ones that have a little phone next to them saying we need to call a doc before we give it. So most EMS services carry drug boxes with a variety of cardiac, pain, anticonvulsants, antiemetics, and other medications specific to their service, which means that even as an AEMT, you'll have access to paramedic level medications. Just because it's in the drug box does not mean you can give it. You have to know your protocols and what meds you can and cannot administer. Standing orders may also allow medication to be administered before even contacting a physician, where local policies and procedures are designed to guide you in specific situations like that. It's also the advanced EMT's responsibility associated with the drug orders to confirm the rights of medication administration. So anytime before you give a medication, is it the right patient, the right medication and indication to go in? Are you giving the right dose? Is it being administered through the right route? Is it the right time to give it? Do you have the right education behind it? And you also need to be educated in these meds before you give them to the patient, let them know what their side effects may potentially be. They have the right to refuse, the right response and evaluation. If I give this, the effect should happen here. And then the right documentation after that, and how we're going to document it within our narratives and our drop-down screens on what we're giving for a med. Some procedures for administering any medication would be obtaining an order from medical control. So having the knowledge of each medication that you carry on your ambulance is critical, and also to safe patient care. You have to know what you carry for your level, right? You do not have to know the indications of all the paramedic meds. It's not required. You need to know what's indicated for the medications you carry. Know when and when not to administer a med. Just because the protocol says you can do something does not mean it's the right time to give that medication. Acute coronary syndrome says for you to administer aspirin and nitro. Well, if they're allergic to aspirin, you probably shouldn't be giving it, right? And if they have an allergy to nitroglycerin or they're hypotensive, again, shouldn't be giving it. So know each medication, know which medications have specific intervals for repeat dosing. Nitro being like every 5 minutes. And the appropriate intervals at which they are administered. So if you give nitro after nitro after nitro after nitro, our patient's vasculature is going to become so dilated that our blood pressures are going to tank down. The patient's not going to make it through it. So again, timing. Make sure the medical control understands the situation. You've got to paint a picture when you talk to the physicians, all right? So if they ask you, when you call, you need to know the patient's name, age, chief complaint, things like that as well. But before you start making phone calls, again, age, you need to know the weight of the patient so you can give them the physician the weight so you can do your drug calculations, the clinical status of the patient. You know, are they unresponsive? If they are, why are we popping nitros in patients that are unresponsive? We can't, right? Allergy history. If they're allergic to it, we don't give it. Any kind of medical problems that could coincide with what's going on. Other drugs that the patient may be taking, getting a good medical history in your sample. It is critical that you obtain and communicate complete, accurate information about the patient to the physician. Everything going on, vital signs, cardiac monitor, rhythm interpretation, patient presentation, age, sex of the patient. Verify that the patient is the right patient in the situation where there may be multiple patients present. Right? If you're assisting a patient with medications, be sure it is prescribed to that patient. So if you're giving someone an albuterol inhaler and you're assisting, make sure it's not their kid's inhaler, right? So those are the things you want to look for. Make sure that you understand the physician's orders. If a physician gives you an order, repeat the same order back to them and get the physician's name, right? Repeat any orders word for word for that verification. The physician may be busy doing something else and not paying attention to what you're looking for and give you an order to give something that's completely off or a medication that you can't even administer because it's not within your scope of practice. Medical control doctors, a lot of them have no idea what you can and can't do in the field at the advanced EMT level, even paramedic level. All right. You want to, and also another thing too, as far as disposal, you want to dispose of any syringes and needles safely, right? They always say we do not recap needles. There are times that we have to. Let's talk real world for a minute here. In National Registry standards and testing phases, looking at the book, we don't recap a needle, okay? But there are times that we have to recap. There are types of needles that are out there that don't have mechanisms to safely cover the top of them so you don't get poked yourself. And if you do have to recap them, there's a specific method that you can utilize to make sure that you don't get stuck, and I can show you guys that on Sunday. Monitor the patient for possible adverse side effects. We have to continue monitoring our patients after every medication we administer. And then properly document my actions or your actions and the patient's response on the patient care report. So if you use like charts, soapier, whatever method you utilize, narrative form, story form, on the reassessment section of your narrative, you have to put down the responses to the medications you gave. And that goes as simple as giving somebody oxygen. Was there a change on the reassessment? Did they get better? Did they get worse? Always check your IV site for patency. Even though you get a line and you do an IV and it's successful, you push the med, everything's going well. If the patient bumps their arm, that can blow the vein at times. So always make sure your IV vascular access points are always maintained. Make sure they haven't infiltrated. So always take a look at the arm, especially when you're giving someone a liter of fluid. If it's gone through the vein and it's infiltrated, their arm's going to blow up like a balloon. We don't want that to happen. That can actually do more damage than good. So specific medications that the AEMT can administer. And these are ones that you guys need to memorize, right, for the national content. Okay, not the local protocol, the national contents that you will be tested on, right? So the AEMT may administer the following medications: oxygen, oral glucose, right? Oxygen being a gas through inhalation, oral glucose is a buccal administration. Glucagon is an IM administration. Please do not give an IV. That is not within your scope to do so. That's a paramedic skill, right? So glucagon help with the diabetics. D50, which we do not carry in the field anymore in New Hampshire. We carry D10 now instead. But D50 is still the national standard, which you will be tested on your national practical, right? They'll have you do a D50 administration. That's for diabetics with hypoglycemia. Same thing with glucagon. IV fluids being D5W, which is 5% dextrose in water. Normal saline and lactated Ringer's solution. All right, normal saline is a 0.9%. It's an isotonic solution versus lactated Ringer's, which is full of electrolytes. Epinephrine, intramuscular, IM, or subcutaneous. That epinephrine is 1 to 1,000 mixture. MDI medications like albuterol, meter-dose inhalers. Nebulized medications like albuterol through a true nebulizer. Nitroglycerin sprays, tablets, and pastes. All right. Sprays and tablets are usually 0.4 milligrams, where paste is done in inches. Nitrous oxide being a gas which is inhaled, self-administered to the patient. And that also is a pain medication, only used for orthopedic injuries only, not for anything with abdominal pain or anything else, because you don't want to fill an injured organ full of a gas. That's bad, right? So nitrous oxide, pain management. Naloxone, okay, can be given intramuscular, intranasal, intravenous, interosseous, all different methods for overdose, for opiate overdose. Aspirin being a platelet aggregator or an antipyretic. These are given to make platelets less sticky and used in acute coronary syndrome. Others are based on local protocols. So you have other medications like, and we'll go over all these on Sunday as well. But you also have the ability to administer epi 1 to 10,000 for cardiac arrest. You also have Zofran or ondansetron, another name for it, 2 to 4 milligrams, which is intravenous, intramuscular. It can be also given PO as well. So there are other medications that we do carry as an advanced EMTs for the state of New Hampshire. You also have duonebs, which is ipratropium bromide and albuterol mixed, which is also not a national standard one. So when you take your national registry exam, the medications that are on this list here will be the ones you'll be tested on, not the ones for New Hampshire. All right, everybody got that? And we'll cover more of those again on Sunday. All right. So quickly going over the basic cell physiology. So the cell membrane being encloses the cell, which compounds must move through the membrane to enter a cell. Composition of the cell membrane allows it to have a selective permeability. Okay, and then composed of the phospholipid bilayer, which is an important barrier to move to fluid movement and acid-base balance. All right. So it all depends on how we're administering and how it attacks the cells, especially when doing fluid administration. All right. So we'll talk about that in receptors too. Electrolytes are atoms that carry charges, positive and negative. So 2 or more atoms bond together to form a molecule. Molecules are with carbon atoms are considered organic molecules. Molecules without carbon are called inorganic molecules. All right. Inorganic molecules give the rise to electrolytes when they disassociate in water into their charged component. Electrolytes or ions are reactive and dangerous if left to circulate within the body. So water in the body helps to stabilize that electrolyte charge, so the electrolytes can be used to perform the metabolic functions that are necessary for life. So why don't you guys give me a couple of the electrolytes within the body? Go ahead and throw some out there.
Potassium.
Yep, there's one. What else we got? We got sodium, potassium, calcium, magnesium, right? All these different electrolytes within our body that help. Phosphorus, right? All these different electrolytes that help move and function the body, including electrical conduction of the heart. And if we have an imbalance of electrolytes, that can change a lot of things on the homeostasis level, including arrhythmias within the heart as well. And we'll cover more of that in depth when we get into cardiology. So the cation, which is an electrolyte with an overall positive charge, anions are electrolytes with overall negative charge. And then sodium is the principal extracellular cation that needed to regulate the distribution of water throughout the body. So we have to have sodium to regulate that water, right? So what medication do we have in our availability to help someone with sodium? We're not just going to put salt into an IV. What medication do we
Saline?
use? Yeah, saline, right? Normal saline or sodium chloride. Yep. So with that, major factor in adequate cellular perfusion, right? And then also a major component of the circulating buffer system as well. We have to be able to have sodium to help move things through cells, right? To move them through the cells itself and help also, we'll cover this here. So the sodium potassium. So sodium is Na and then potassium is K. Excuse me. Pump is helped by the presence of insulin and epinephrine. The sodium potassium pump is what helps produce an electrical charge for the heart to be able to fire. And then obviously calcium, magnesium, things like that are also built into it as well. But the sodium potassium pump is very important. Now, what medication is out there, not that we carry, but a patient can take on their own that is a non-potassium sparing diuretic? I know what was that?
I thought it was Lasix.
That's it. Lasix, furosemide, non-potassium sparing diuretic. That is a it's also called a loop diuretic that stimulates the ascending loop in the nephron of a kidney, right? But when you're peeing out, urinating, you're actually depleting your potassium in your system, and you're not able to replenish it as fast, therefore causing issues with your sodium potassium pump, but then before it cause arrhythmias as well. So as you can see, there's the mechanism of action. Understanding how those things work can tell you what potentially could be going on with your patient. So you got a patient that overdosed on or took way too much, say they tripled their dose because they have dementia of their Lasix. You get called for a patient with chest pain and they have arrhythmias going on. Maybe that's what's causing it. They need potassium, right? So one of the things you can help with that and what carries potassium in it is lactated ringers. So hypokalemia is low potassium, can result in a decreased skeletal muscle function, gastrointestinal disturbances, and alterations in cardiac function. On an EKG, okay, this is kind of a side note, which we're going to cover later on a 12 lead, the T waves will be flat. Okay, that would indicate a patient has low potassium. Hyperkalemia or high potassium can result in a hyperstimulation of the neural cell transmission, resulting in cardiac arrest. What we're going to see on an EKG is tall, peaked T waves. And if some of you don't know what T waves are, we'll get to that during cardiology, but I want you to have an understanding now that if you see those, it possibly could be a hyperkalemic patient, right? And this can result in cardiac arrest if not treated appropriately. These patients need to get to a hospital, an ER, so they can start treatment. Calcium, right, is a principal action needed, or cation needed, for bone growth and the functioning of heart muscles, nerves, cell membranes, and blood clotting, right? So if a patient has hypocalcemia or low calcium, this can result in overstimulation of the nerve cells, resulting in the following: skeletal muscle cramps, abdominal cramps, carpopedal spasms in the hand and feet, hypotension, and vasoconstriction. So what else can cause carpopedal spasms? Okay, dehydration. What about hyperventilation? Can that cause it? Everybody should be replying or saying yes, right? Hyperventilation, right? So a patient that's hyperventilating can cause those spasms due to hypoxia. Okay, they're breathing fast, their carbon dioxide is low in the system based on your carbon dioxide. And will be breathing low because you're breathing too fast, hyperventilation, right? But also could be the fact that they're hypocalcemic. Hypercalcemia or high calcium can result in a decreased stimulation of nerve cells, resulting in skeletal muscle weakness, lethargy, ataxia, vasodilation, and hot flush skin. So bicarbonate levels are related to the conditions of acidosis and alkalosis within the body, right? Anything with bicarb is metabolic. We talked about that in the last class, looking at your acid-base balance stuff, all right? Chloride primarily regulates the pH of the stomach. It also regulates extracellular fluid levels. And then phosphorus, which is an important component of the formation of adenosine triphosphate. So as you can see, a lot of this stuff plays into that homeostasis. And if our electrolytes are imbalanced, right, we can have arrhythmias, we can have death, we can have a lot of things can happen. I'll just say seizure, coma, death, right? A lot of things can happen to the body if our electrolytes are off. Now, let me put this into perspective on 911 calls, right? Most of us have been in this group, have been in the field for 5 years plus, right? Most of us have. How many times have you responded to a residence where they said, the physician is requesting transport for abnormal labs? How many? You guys can unmute, talk about it, right? We've had those before, right? Yeah, often. It often happens. Many times you've gone to this. So they respond out there, and we get to the home. Fairly common, yeah, Justin, fairly common stuff, right? So we respond out, we get there, we're at the paramedic level, and what does that paramedic usually do? This call is what?
Give it to the basic or the A.
Yeah, they downgrade it. Mike Ball, I love it, 12 lead. A lot of medics don't do it. They turf it down to the BLS level. Okay? I just covered 15 minutes of body or electrolyte stuff with you guys. This is dangerous stuff. Just sodium alone being off can cause a patient to go into cardiac arrest, potentially. Right? Patients that have high potassium could put them in cardiac arrest. We need to have these patients monitored. This is an ALS call. Hands down, ALS. And if they're BLSing these calls, then they have no idea what lab values truly are and what electrolytes actually do to the system. Because you can't BLS this stuff. Right? Where I work currently, we're on a big push now company-wide. And the owners of the company that I work for, they actually asked me to start putting on more lab value classes for all levels. So they have the understanding of how critical a patient's electrolytes being off can truly be. Right? So again, if you have a patient, you're at the A level, there's no medic around, that's perfectly fine. But you've got to put patients on monitors. You've got to do 12 leads. You have to get these patients monitored for the ride. Please do not BLS these patients. Get an IV in place in case something changes during transport, right? You don't have to worry about ruining their labs if you give saline, because guess what? They already had them drawn, right? So you're just going to draw another set anyways. When you put an IV in, you're drawing labs anyways, depending on what service you work for and what area. All right, there's my little soapbox on electrolytes. Very important to understand this can truly kill a patient if they're off. All right, so body fluid composition. So fluids found in the body are composed of dissolved elements and water. So a solution is a mixture of two things. One being a solvent, which is the fluid that does the dissolving, and two being a solute, which is dissolved particles contained within that solvent. So looking at some fluid electrolyte movement. So balance across the cell membrane, you'll see more of this stuff in the next slide, but balance across the cell membrane has two components. There's a balance of the compounds and a balance of the charges as they go through the movement of the through the barrier. That's it. I'm trying to show you guys more of this in the next slide. So materials that flow from an area of higher concentration to one of lower concentration, establishing a concentration gradient, all right, depends on whether the cell membrane will allow the material to pass through it. All right, so we talked about the cell membrane being there and that gradient that it creates. We're taking things from a higher to lower concentration, so that way that things start to even out. And there are two methods of moving electrolytes, right, or gases, right? We have two different ones. What are they? What are the two things that can be utilized to help move things through a gradient? One's a gas, one's a fluid.
Water?
What was that?
Water?
Okay, that helps move it, but there's two names for it. One's called, I think I may have lost on the question.
Osmosis?
Osmosis, yes, that's being one. And the other one is?
Diffusion.
Fusion.
Two things you have to understand. We create that gradient moving through. So this is diffusion here. Diffusion, right, are compounds or charges concentrated on one side of the cell membrane that will move across to an area of lower concentrations. As you can see out here, the outside moving in. So this is simple diffusion. We have lipid soluble molecules on the outside that pull through based on charges, right? Electrical charges that pull through a simple diffusion through the gradient wall down the middle into the inside plasma membrane. Okay? Pulling from greater concentration on the outside to the inside where it has lesser concentration across the gradient to meet homeostasis. If we have an imbalance, that's where our labs start becoming off. Does that make sense? Okay, good. So with filtration, okay, is a type of diffusion used by kidneys to clean blood. We filter in our kidneys and the nephrons. Things start moving around and filtering out. The water carries dissolved compounds across the cell membrane of the tubules of the kidney where the dissolved components are trapped. So for active transport, the method used to move compounds to create or maintain an imbalance of charges. So an example would be like the sodium-potassium pump, where the cells use sodium on the outside of the cell and potassium on the inside of the cell for depolarization. Okay, remember that word, depolarization, okay? Cells use energy in the form of adenosine triphosphate, or ATP, and they actively transport compounds across that membrane. When you look at an EKG strip, each wave actually means something, P, QRS, and T. The P wave on an EKG is atrial depolarization. Your atria is depolarizing. The QRS wave is your ventricle depolarization, right? Buried in the QRS wave is something that you cannot see. At that time, your atria is repolarizing, and then your T wave is your ventricles repolarizing, okay? And if they repolarize with too much potassium, we're going to see that tall peaked T wave. If there isn't enough potassium, we're going to see the flattened T wave. That's how that works. We have to make sure that the sodium-potassium pump that controls our electrical conduction system of the heart is passing through diffusion, okay, back and forth to meet homeostasis to allow our heart to pump effectively. Does that make sense now? A little more better? Okay, good. Osmosis is the movement of water, not a gas, but of water across a cell membrane. This occurs when there are different concentrations on each side of the membrane. Increasing the concentration of sodium in the extracellular fluid decreases the water in the fluid. The water then moves out of the cell to create a balance of water molecules and to dilute the increased concentration of sodium. All right, this is where osmotic pressure comes in. So osmotic pressure increased yet balanced volume puts pressure against the cell wall, right, as you can see in the photo. Putting pressure on the cell wall will then allow it to escape through, right? So tonicity of the solution is the effect of the osmotic pressure on a cell, okay, as you can see here. Hypertonic, where the net water movement is out. Isotonic is a normal cell, right? Then we have hypotonic, where net water movement is in, okay, causing a cell to burst, right? So you look at the slide at the bottom, okay, low solute concentration and extracellular fluid, right? We do carry hypotonic and hypertonic solutions. Not, well, Massachusetts carries hypertonic, right? This would be used more for trauma patients. So if you think about this, we carry isotonic solution, normal saline, right? That's isotonic. If we give them a liter of fluid, they only retain about 200 mLs of that. The rest of it is done through the cellular stuff and moves stuff out, and we end up losing it somewhere, okay? Where if we give a patient hypertonic solution, you give them a liter of hypertonic solution, they retain about 800 mLs of that within the body system. Therefore, less fluid, right, and more volume within the system. So it kind of helps out quite a bit, right? So understand that hypertonic, hypotonic, isotonic solutions that we do happen to carry. So other parts of fluid components, water can be intra or extracellular. So intracellular being inside the cell, extracellular being outside the cell. Water levels in these compartments constantly shift. They always have shifting movements. But homeostatic control mechanisms ensure balance is restored, right? So the vascular system functions as a fluid highway and contains cells which can be thought of as another fluid compartment. The vascular system functions as a fluid highway and contains other cells as well, right? So there may be a time if patients have too much fluid, we start seeing that edema, or we have patients of what they call third spacing, right, where that fluid goes into that third space between there. Okay, that's part of the whole fluid highway. So extracellular compartment or intravascular water portion of the circulatory system surrounding the blood cells. Interstitial is water outside the vascular system between the surrounding cells. So if we start seeing edema, that's really called interstitial fluid, right? There's not much we can do with a patient that has right-sided heart failure and interstitial fluid buildup in the extremities, other than trying to make a container bigger by utilizing nitrates, but the pressures have to be good enough to do that. Okay, so a lot of times we'll give, well, what medication could be given to help reduce the fluid within their system? Or what classification of medication can be given? So I see Mike saying Lasix, a diuretic. Yep. That's why you always want to look and say, well, what do you want? I take a water pill. Okay, which one do you take? Because they're going to be on a diuretic. What is something that we drink, most of us drink on a daily basis that's a diuretic?
Caffeine.
Coffee. Coffee, tea, right? All right. So there are 3 compartments in the human body which account for 60% of total body weight. intravascular, which is extracellular, interstitial, which is extracellular, or intracellular. Okay, so you have extracellular and intracellular fluids. Contains for about 60% of the total body weight. Extracellular fluid, or what they call ECF, occupies any area that is not inside the cell. This acts as conduits for transferring gases and nutrients between vascular and intracellular fluid compartments. Also, levels are regulated by the presence of sodium. So we have to have sodium. Okay, so if we have a decrease in sodium, the levels are not going to be regulated, therefore causing more problems with the system, and also causing, there's also a train of thought, causing irregularities in rhythm, in your heart rhythm as well. So this accounts for 16% of total body weight, the interstitial fluid, which occupies the microscopic spaces between the cells and consists of a gel-type protein that helps disperse water evenly throughout the interstitial compartment. This also helps move water freely between cells in the vasculature. Perfusion occurs in the capillaries as a result of high hydrostatic pressures and osmosis in the capillary beds. So intracellular fluid, or ICF, are within the cells of the body, and they have large proteins within the cell that can draw fluid into the cell. And then we talk about sodium ion, which is drawn into the cells, are removed via the sodium-potassium pump to prevent cellular lysis or a rupture of the cell. We have to have that movement going in and out of the cells and the vessels in order to maintain homeostasis and also make sure we keep our regular rhythm, right? We want to make sure we have good fluid. If we have a deviation, the patient doesn't meet that homeostasis anymore, then we're going to start seeing changes in EKGs, the different arrhythmias, PVCs, PACs, things like that, which again, we'll cover those later. We're also going to see changes in blood pressures, changes in heart rate. A lot of things can change, changing your respiratory rate depending on if it's messing with the buffer system and they have to truly expel carbon dioxide or if they're retaining too much. So all this stuff plays into effect if our body isn't meeting on the even playing ground. So with that being said, it's very important to make sure that our body has enough fluid and we're not hypovolemic. Hypovolemia can change a lot of that. So with fluid balance, some form of water surrounds all cells. There's always some form of water around them. This plays a part in cellular metabolism and maintenance of homeostasis. So the body will then adjust to the changes in the balance between ICF and ECF by retaining or eliminating water. Fluid levels then in the body are balanced when intake equals output. And we start balancing our fluids out. Maintenance of the internal environment of the cell is regulated by feedback systems. So now we have dehydration. So depletion of the body's total systemic fluid volume. It's more common in older adults and young children. It could take days to manifest. May be the result of a medical condition causing that. As fluid is lost from the vascular compartment, the body reacts by shifting interstitial fluid into the vascular area. This forces a shift of fluid from the intracellular to the extracellular components or compartments. If this happens, we have total systemic fluid deficit that starts to occur. So why don't you go ahead and give me some signs and symptoms of dehydration? What do you guys have? Okay, so skin tensing, tachycardia, What else we got? All right, see tenting skin, tachycardia. There's a lot more than that. All right, skin color, headaches, altered mental status. What else happens if we're severely dehydrated? Decrease urine output. Yep. Ooh, sorry. Can't pee. What happens if a patient can't pee anymore? What can happen to the kidneys? Right. And you say a kidney failure, Mike. Would you agree with acute kidney failure? Yeah, perfect. Okay. Kidneys are shutting down. Toxins build up, causing shutdown. Yeah, exactly. Right. So we have acute kidney failure or acute renal failure. What does this patient truly need then? Dialysis. Perfect. Right. So decreased level of consciousness, orthostatic hypotension, dry mucous membranes, tachycardia, poor skin turgor, flushed dry skin, and decreased decreased urine output. Right. So what are some causes of dehydration? Firefighting activities. That's one of them. Yep. What else? So exercise. Mike, I'll take flu, put that in with infection. Sepsis, absolutely. Absolutely sepsis. Diarrhea. Right? What else? Vomiting, working in heat without drinking enough. Yep. Well, I think I might have missed. There's one there that you guys all missed. What can cause dehydration? Summer day on the beach. Drugs, alcohol. One thing that people don't think about, but is actually very common, is hemorrhage, bleeding. Right? That can cause significant dehydration as well. Right? Insufficient fluid intake, infection, sepsis, GI drainage, vomiting, diarrhea, right? Anything that can reduce that fluid. With this dehydration, can that also deplenish your electrolytes? Yes. Yep, it can. That's why we carry lactated ringers. Overhydration is a total systemic fluid volume increase in the body, where fluid fills the vascular compartments, filters into the interstitial compartment, which is called third spacing, and is forced from the engorged interstitial compartment into the intracellular compartment, as you can see in the photo. Fluid backup can result in death, right? So if you're giving a patient fluids, whether it be fluid challenges, fluid boluses, whatever you may be giving them, right? For adults, every 500 mLs you give, you should be checking lung sounds to make sure that you don't push that fluid into the lungs, right? Because if you do, now you've caused acute pulmonary edema.
Would we also check for pitting?
Yep, exactly. Like you can see on the screen here, George. Perfect. Yep, look for pitting edema as well. So a lot of patients will not feel comfortable, their legs up. They're going to want to be in a seated position to help with that fluid as well. Okay, so pitting edema. If you see this, a lot of patients are on some type of water pill, whether it be Lasix, hydrochlorothiazide, which is otherwise known as HCTZ. You know, the different ones that are out there, torsemide, other medications that would be more of a diuretic of some sorts. So signs and symptoms would include shortness of breath. If we see shortness of breath with this, probably pulmonary edema. Puffy eyelids, edema, right? Polyuria, what is that? What's polyuria?
Urinating constant,
Excessive urination.
Yep,
excessive
lots of-
urination.
Perfect. Yep. Moist crackles or rales. Okay. If you have a patient that has crackles within the lungs, if it's acute pulmonary edema, it will be on both sides, not just one. Right. Acute weight gain while they've gained, and that's another thing too. Patients that are in heart failure, a lot of times the docs will say check your weight every 7 days and see if you have any changes. Right. So they have an excessive weight gain over the past couple of days. They're retaining fluid. Causes would include unmonitored IV lines. Right. That's not an oops. That's a no-no. That cannot happen. Monitor your lines. Kidney failure or prolonged hypoventilation as well. So IV fluid composition. We'll go over a couple more of these here. Then we'll take a break. Our compounds and ions are dissolved within the solution are identical to the ones that are found in the body. Each solution is a concentration of a solute and a solvent. So sodium is used as a benchmark to calculate a solution's tonicity. Concentration of sodium in the cells of the body is approximately 0.9%. A common IV fluid is normal saline, which is 0.9%, which is your isotonic solution. Altering the concentration of sodium in the IV solution can move the water into or out of any fluid compartment within the body. So we have someone that has 3% sodium versus 0.9, there'll be a lot more moving of that as well. Some types of IV solutions categorized as crystalloids or colloids are based on their dissolved components or makeup, right? So they are dissolved, they are also categorized as isotonic, hypotonic, and hypertonic based on their tonicity. So your crystalloid solutions are dissolved crystals within the water, right? They contain compounds that quickly dissociate in a solution. So the best choice for pre-hospital care of injured patients within the body with body fluid loss. That's why we look at crystalloids. The rule would be a 3-to-1 replacement rule. 3 mL of isotonic crystalloid solution is needed to replace 1 mL of patient blood. What did I mention earlier? Okay, it's a 3-to-1. We have to give 3 mL of fluid for 1 mL of patient blood, right? Where in turn, if we had a hypertonic solution, it would be different ratio, okay? These do not have the capability of carrying oxygen, right? Boluses of 250 mL should be given to maintain perfusion of a radial pulse, but not to restore blood pressure. When they say bolus, that's a push of fluid, not just a normal drip. Increasing blood pressures with IV solutions dilutes the remaining blood volume that you have. So what I keep talking about before, if we're flooding someone with more and more fluid that's hypovolemic, okay, all we're taking is we're diluting their system. We're turning their blood into Kool-Aid. That's all we're doing. That's not helping the patient at all. What they really need is less fluid, but be able to retain more volume, and they also need blood products right away. Okay, that's why it's so important. If you have a patient that's in a motor vehicle accident or a traumatic injury that's bleeding and potential bleeding internally for hypovolemia, get that paramedic on board. They can give something called tranexamic acid or TXA to help facilitate clotting, right? And if they have the ability to give hypertonic solution, depending on what state you're working in, they can help with that fluid replenishment and not overload the patient. So by increasing this also may increase internal bleeding by interfering with homeostasis. Our body needs to be able to clot. If we give more fluid and we dilute the blood so much, we're not going to be able to clot, and they'll bleed out even more, right? So the old days, we were always taught fluids, 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 fluids. Not anymore, right? We look to maintain our systolic blood pressure of 90 systolic, 90. That's it. That's enough to perfuse the body, right? If we have a person who's bleeding out and we get their pressures up to the 140s, 150s systolic, we've given them too much fluid. We cannot give them that much. It's bad. Right? So we're going to go over the next 5 more slides. We'll take a break. Colloid solutions contain molecules, usually proteins, too large to pass out of the capillary membrane that remain in the vascular compartment. They have a very high osmolarity, which then draws the fluid from the interstitial and intracellular compartments into the vascular compartment. They work well in reducing edema while expanding the vascular compartments that are there and could cause a dramatic fluid shift. IV solutions are also categorized by their tonicity, which we talked about, and there are 3 categories related to tonicity are isotonic, okay, which is going to be your 0.9% sodium chloride, normal saline or lactated ringers, as we normally carry on a truck, your D5W, which is your hypotonic solution, which we really never give unless we're mixing it with another medication, and at your level, at the advanced, we're not going to be doing that, right? You may take a transfer sometime with a hypotonic solution running. That's perfectly fine. Then you have your hypertonic, which is 3% saline, blood products, and albumin, right? So like I mentioned before, okay, we have our hypertonic solutions out there. If you can see, it goes almost in line with blood products. This is why hypertonic solution is so important. But if you give somebody 5 liters of hypertonic solution, you'll probably kill them. You give someone 5 liters of saline, they have more chance of, they'll probably stay alive, but you've just diluted their system. Does that make sense? Yes. So as of right now, for this area, Massachusetts is the only one that truly carries that hypertonic saline right now. Maine and New Hampshire do not carry that yet. It doesn't mean that you won't see it on interfacility transport. So nearly the same osmolarity as serum and the other bodily fluids. This is more of your your hypertonic. This expands in, the contents of the intravascular compartment without shifting fluid to or from other compartments itself. Fluid remains in the vascular compartment, so be careful to avoid fluid overloading, like I talked about before. All right? Patients with hypertension and heart failure are at great risk for fluid overload because their heart is not pumping effectively. Right? Whether it be right or left-sided heart failure or complete heart failure, right? They can't push fluid. So if you give them too much of the hypertonic solution, you can quickly have fluid overload. Lactated ringer solution is generally used in the field for patients who have lost a large amount of blood. Any patient that goes to the OR from an ER always has a liter of ringers running, okay? Because it coincides with blood a lot closer than saline does. D5W is a special type of isotonic solution, hypotonic, right? Or isotonic solution, as long as it remains in the bag. If it is considered an isotonic solution, after administration, though, the dextrose is quickly metabolized and then becomes a hypotonic solution, right? So it starts off as isotonic, but really can't call it that because once it's administered in the system, it becomes hypo. So let's talk about hypotonic solutions then. Right? They lower the concentration of sodium in than the cell. And also they hydrate the cells well, depleting the vascular compartment. They may be needed for a patient on dialysis when diuretic therapy dehydrates the cells that are there. Okay, so you may see that D5 running. They also may be used for hyperglycemic conditions such as diabetic ketoacidosis, when high serum glucose levels draw fluid out of the cells. So they may give that hypotonic solution to assist with that. And you're like, well, it has 5% dextrose in it. Yes, I understand it does. But it's going to help slow that production down. Dangerous to use because they can also cause a sudden fluid shift from the intravascular space into the cells. And it's dangerous to use on patients experiencing a stroke or head trauma, or patients with burns, trauma, malnutrition, or liver disease as well. All right, and last slide, and then we'll take the break. Hypertonic solutions, osmolarity is higher than serum. They have more ionic concentration than serum inside. They shift body fluids into the vascular space and pull fluid and electrolytes from the intracellular and interstitial compartments into the vascular compartment itself. They help stabilize blood pressure. They help increase urine output and reduce edema. They rarely use in the pre-hospital setting. We don't see much of this. Just like I said, Massachusetts just put this into their protocols. I think you're going to start seeing more of this in the future. You have to have careful monitoring is needed to guard against fluid overloading. So again, we're not going to give them as much. It's different monitoring with this, and should not be given to patients with diabetic ketoacidosis or other risks of cellular dehydration. All right, so before we start getting into techniques and administration of IV therapy, why don't we come back at 7:18? Give you guys 10 minutes.
This conference will now be recorded.
All right, so let's talk about techniques and administration. So, biggest thing with IV is making sure you do the best you can to keep the equipment sterile. Now, yeah, I understand we're in the back of an ambulance. Nothing's ever sterile. Neither is an ER, right? But we have to do the best we can to make sure we keep it as sterile as we possibly can. We also need to make sure we gather and prepare all the equipment first. Everything needs to be out and ready for us to go. This includes a elastic constricting band, not a tourniquet. They're constricting bands. An antiseptic wiper solution, gauze, taper adhesive bandage, appropriate size IV catheter, right? IV extension set, administration set, a saline flush, usually in 10 mLs, right? And then, like I said, the appropriate catheter you're going to be utilizing. The most average catheters we utilize are 18s and 20s. If you're doing 16s and 14s, right? 14s are very rare. I've been doing this now for a long time. I've been doing this for many, many years. And honestly, I may have put in my time since 2006 when I started doing IVs, maybe 10 14 gauge catheters. So again, we really don't need big lines like that. 18s can handle traumas very, very well. I guess if you want to put a 16 in, that's also another option. But again, we don't need to be going that big. The whole method of go big, go home, believe it or not, big catheters hurt patients, right? You can push a lot of fluid through an 18 gauge catheter. Let's see. So with that being said, we need to make sure that once we get all of our stuff that we're going to be utilizing, that we choose an IV solution that we're going to be needing. So do we need those electrolytes? What do we need at this point for a solution? So we need to identify the situation and the need for the patient. Remember, we got to make sure it's the right dose, right time, right med as well. So I'm just plugging in my computer really quick. It's almost dead. All right, so is the patient's condition critical or is the patient condition stable? Does the patient need fluid replacement? Do they need it? Right? So the bottom of each IV bag has an access port for connecting the administration set. So as you can see, they're kind of folded down here on the screen. There's ports at the bottom of every one of these bags. All right, a removable pigtail that represents a pinpoint of no return line protects the sterile access port that's there. Each bag, sorry, IV solution bags come in different fluid volumes. They could be hundreds, 50s, 100s, 250s, 500s, 1,000 bags. And depending on what you're diluting, they also have 3,000 and 5,000 ml bags as well, but those aren't usually for IV therapy. Usually it's for continuous flushing of Foley's, or bladder irrigation, I should say. What you can't see on here, maybe you can, the bottom of the Tasbag, the little orange port there. Every bag has a medication port and also has a drip port, right? So we're mixing medications, right? So choosing the right administration set, right? We have 10s, 15s, and 20 mLs. Those are called macro drip sets. Then we have our ones that have a little like needle inside. Those are called micro drip sets. Those are 60 drops per ml versus macro sets, which would be 10, 15, sometimes they even have 20s. All right. So this moves fluid from the IV bag into the patient's vascular system. It has a piercing spike protected by a plastic cover. Okay, keep this in mind. Those plastic spikes on top, they're very sharp. You can puncture your skin. Right? There's also different sizes for different situations and patients. So usually we do the smaller ones for patients, or the 60 drop sets are meant for more medication administration and pediatric fluid administration. All right, sorry about that. So most strip sets have a number of visible on the package itself, which indicates the number of drops it takes for 1 milliliter of fluid to pass through the orifice and into the drip chamber, as you can see here. Sorry, I just saw that Matt had to take off for a call. All right. All right, so let's go over the different sets. So a micro drip set allows 60 GTTs. GTTs are drops per ml. So a small needle-like orifice inside the drip chamber. Wish I had a better picture of one here, but they don't. But I'll show you guys all this on Sunday. Ideal for medication administration or pediatric fluid delivery and easier to control the flow. A macro drip allows 10 to 15 drops. They also have 20s as well that are out there, which is a large opening between the piercing spike and the drip chamber itself, which allows for rapid fluid replacement. Then you have special macro sets. These are called blood sets. As you can see on the screen here, this is considered a blood set. And that little white thing inside the chamber, it's called a filter. All right. Again, you're not going to be dealing with those at all in the field, unless you're assisting a paramedic for a transfer that has blood running. So this is a special macro set designed to facilitate rapid infusion, replacement by manual infusion or large IV bags or IV blood replacement combinations with that. Right, but then we also have to make sure that we're choosing a site. So having an idea of where veins are located will help you try to locate them, especially if they're bigger patients. Having a general idea of the layout will definitely assist. So we got to select a vein. In order for us to select a vein, we got to put a restriction band on. Right, so we're going to put a restriction band across the upper part of the bicep, allowing for blood flow to kind of put pressure against to where the restriction band is located. This will allow, hopefully, in turn, for the veins to actually pop out more so you can see them. This helps us locate the vein. You want to make sure you're locating the vein with the straightest section or straightest appearance, the straightest section that's there, instead of ones that have a lot of curves. As you're trying to advance your catheter in, you don't want it to bend and turn because it may puncture the vein. Try to find some straight ones. You want to choose a vein that is firm, round in appearance, or is springy and when palpated, right? And avoid areas of the vein where it crosses over joints because that can also cause it to puncture through. Puncture through. As you're pushing on it, hold it down for a second, okay? Because if it has a pulse, then you're in an artery, and you don't ever want to stick an artery, okay? So make sure you look for that. Look for the IV, the vein sites, right? We're not going to be doing any veins up here or any IVs up on the subclavian or internal extra jugular at all. EJs are for paramedic use. However, the cephalic vein, the median cubical antecubital vein here, to the basalic vein on this side over here, those you can utilize. You can stick IVs in biceps, the forearms, the hands. You can even go in the dorsal veins of the feet as well. Access is access. So choose a vein that is firm and round. Try to look for one, palpate it. I'll show you the next slide here. Yeah, the feet do hurt, but access is access if we need it though. But yes. As you can see, this guy's got pipes on here. So we try to find the straightest ones. Do a favor for the hospital staff. If you think a patient's going to be admitted or going to be getting IV fluids through via pump, if you put them up in the ACs and the patient bends their arm, it can make the pumps go off, and then it becomes very annoying. On top of that, fluid administration doesn't happen as fast. Forearm veins are one of the best veins you can get access to because they can move their arm around in any direction. And what's not going to happen is the pumps aren't going to start alarming. On top of that, they can't occlude their own vein. Okay. So avoid any extremities that show signs of trauma, injury, or infection or edema. We don't want to infiltrate any of that. We're going to avoid any extremity with dialysis fistulas. Do not do IVs on where fistulas are located. And avoid any extremity on the same side as or prior mastectomy or lymph node dissection surgery. They say avoid, but if that's all the access you have, you might have to go into that area. For critical patients, always start at the antecubital fossa or higher, and you start distally and work proximally. Why would that be? What are your thoughts? Why do we always start distal and work proximal?
Because
Because
if
if
you
you
blow a
blow
vein
a
on,
distal vein, then the fluid doesn't backflow. If you blow a distal vein, the fluid is not going to go down into your next site.
Right, exactly. So we want to start low, work our way up high, right? So the hand veins, as far as hand veins go, they can be tricky, and depending on like the skin of the patient as well. And I'm not talking about color of skin. I'm talking about if they're like outdoor workers or things like that that can make it very tough to access. I've had patients that I put 18 gauge catheters into before, and I've seen the actual needle bend prior to or like bow before popping through skin. Right. So it all depends on the type of patient you're dealing with, and can you see the hand veins? Hand veins, you have to come in at a different angle versus you would for a forearm or an AC. So again, it's all going to be based on practice and angle of how you do things. Normally, we go at a 10-degree angle as we access through. Once we see flash, we push forward ever so slightly forward more, then we advance the catheter. Okay, you're going to feel a little bit of a pop as you go through the vein. Then as you pop through, you don't want to push all the way through the vein itself, because then you'll puncture it and you'll end up pushing through the wrong side instead of being inside the actual vein itself, and then that can cause infiltration. Okay, really, it's all practice. This is a simple skill that just takes practice, 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 and more practice again. All right. If you push through, we can result in a possible infiltration. If you give somebody D50 or D10 and you have an infiltrated vein, the problem with that is, leather skin, is necrosis. And D50 is very necrotic as well. So choosing the right catheter, right? There's different types that are out there. What you see on the top, okay, has a vacutainer on one end. These are called butterflies, right? Um, right. These catheters are most common for blood draws in the field, or not in the field, or in the hospital, where we're going to use what they call an angiocath, which is the one down below. And there's different types. There's click ones, there's slide ones, there's all different types that are out there. Be familiar with the ones you have within your service, okay, and practice with those. All right. So as far as catheters go, over the needle catheters are sized by the diameter, referred to as a gauge. We have 24, 22, 20, 18, 16, and 14 gauge catheters. 24 being the smallest gauge, 14 being the largest gauge. Right? Select the largest diameter catheter that will fit the vein you have chosen, or that will be the most appropriate and comfortable for the patient. Most of the time, 90% of the time, a 20 gauge catheter works perfectly fine. Okay? The more distal the IV site will be the smaller the catheter. Please do not start throwing 16 and 14 gauge catheters in people's hands, okay? Please do not do that. That's just cruel and punishment. Over the needle catheters can be used for all adults and most children for long-term IV therapy. So newer over the needle catheters use several different methods to protect against the possibility of contaminated sticks. Okay, so there's a lot of different methods that are out there, different catheters are out there that protect us as a provider and also protect infection of the patient itself too when sticking a patient. So no matter what technique you use, okay, the bevel side of the catheter always has to be up when inserting the needle into a vein, bevel side up. You also want to maintain adequate traction on the vein during cannulation. Traction being pulling back on the skin, pulling tight on both sides. This helps stabilize that vein so it doesn't roll on you underneath the skin, and you have to do multiple sticks. Our goal is to get IV catheters or IV successes on the first stick because we don't want to keep sticking people over and over and over again. So we want to make sure we get that on the first time. Right, we don't do blind sticks. Have an idea of vein layout if you need to, but please do not just start sticking people as a pin cushion to try to find an IV. And I'll show you other different techniques as well on Sunday. Apply the constricting band above the site you have chosen, and then advance the catheter through the skin until the vein is pierced or punctured. If for some reason you can't find a constricting band, you can also use a blood pressure cuff and inflate the blood pressure cuff tight enough so that way the veins actually pop out. Surgical tubing also works. You can also tie gloves around someone's arm as well, if that's all you have. After you selected the insertion site, you want to make sure you prep it with an alcohol swab, iodine swab, or a chloric prep. And once it's been done, please do not touch the site after it's been prepped, okay? Because that just puts more infection on that site. So feel it, find it, wipe it, clean it, then stick the patient. Begin by establishing and inserting an angle approximately 45 degrees. I can tell you right now, flat out, 45 degrees may be too much, okay? If you usually go between 10 and 15 degrees, you have a better chance of not puncturing a vein, right? But again, it all depends on the status of your patient. If the veins are flat, if they're hydrated, dehydrated, on how you're going to enter. And this is over time and practice, you'll figure that out. Begin establishing an insertion of 45, then advance the catheter through the skin until the vein is pierced. Then immediately drop the angle down to approximately 15% and advance the catheter a few more millimeters to ensure the catheter sheath is inside the vein. At that point, you slide the sheath off the needle into the vein and do not advance the needle too far because it can lacerate the back wall of the vein, and then next thing you know, you're going through it. After the catheter is fully advanced, apply pressure to the vein just proximal to the end of the indwelling catheter and remove the needle. Because if you don't, and you don't have a self-occluding catheter, it will bleed all over the place, and dispose of it in a sharps container. Very important that once your stick is done, you do not set it down. It goes directly to a sharps. That is going to be a critical fail on your National Registry skill station, right? Once you stick them, you say, and you pull the IV cap, you pull the needle out. You say sharps out, drop it in the sharps container, and then apply your lock set. If you're drawing blood, you can draw off two different methods. You can use a vacutainer directly to the catheter, or you can draw it through a non-saline filled extension set. Follow local protocols for these for blood tube draws. If you're working in the Ossipee Valley doing your clinical time, if you do an IV, you're getting blood. Okay, it's a requirement for the hospitals. If blood is drawn, it must be drawn before any fluids or medications are administered. We cannot mix any kind of fluids or meds into the blood. If you're having difficulty drawing blood, stop, finish establishing the line, and don't worry about it. Right? You're better off having access than versus blowing a line because you're trying to draw labs. A vacutainer connects to the catheter to assist with a blood collection, as you can see in the photo over here. If you do not have a vacutainer set up, you can draw blood from an IV site using a 15 or 20 ml syringe. You can draw that up and you can just put it right into the lab tubes when you're done. If you draw labs, you have to make sure you label them with a patient sticker, put your initials on it, and also put down the time you drew it as well. As far as securing the line, tape the area so that the catheter and tubing are secured and anchored in case of a sudden pull in the line. So we have tegaderms that go over this as well, then we tape over the line itself. Double check the tubing to create a loop that will act as a shock absorber if the line gets pulled accidentally. Avoid any circumferential taping around the extremity, right, because that can also cause a restriction. And then on your skill drill 13.2 in your books, you'll be able to see the skill drills for that. Any questions for IV therapy? All good? Everybody okay? Perfect.
So we're not to take blood. We're not to, well, I should say, we're not to flush first before drawing blood.
That is correct. You want to pull blood prior to flushing any kind of sodium chloride into it. All right. So changing an IV bag. So do not allow an IV bag to become completely empty because that puts a lot of air in the line. We don't want that. So you want to change the bag when approximately 25 mL of fluid is still left, right? So basically, if you see the bag down almost to the end, as long as your drip chamber is still full, you can easily pull the spike back out. And then what you do is you take that spike and put it into a new bag and then continue your fluid. And document on the bag itself in a permanent marker, number 1, number 2, so we know how many bags of fluid have gone in during the transport. As far as discontinuing a line, which we really will never have to do unless you start a line and it infiltrates, right? Shut off the flow from the line with a roller clamp and gently peel back the tape towards the IV site and stabilize the catheter when you loosen all remaining tape. Okay, you don't want to just pull the tape off and have it bleed everywhere. Another time you'd be doing this in the field, really the only time you're doing this in the field is if you have a patient who's a diabetic and they end up getting a patient refusal with med control orders. Do not remove the IV tubing from the hub off the catheter because it will bleed everywhere. We don't want that kind of a mess. You want to fold a 4x4 or a 4-inch by 4-inch piece of gauze and place it over the site, holding down while you pull back on the hub of the catheter. This allows the catheter to be removed, and you can start the clotting process with the 4x4. You're going to gently pull the catheter in the IV line from the patient's vein while applying pressure to control bleeding. All right. So saline locks. These are locks that these are hooked into the hub to allow you to have a medication like an access port and things like that versus hooking directly into a drop set. So 90% of the services that I've seen out there have these on their ambulances. The ones that don't, those are the ones that don't want to spend the extra cash on them, but they're definitely worth having. So maintain an active IV site without having to run fluids through a vein. Used primarily for patients who do not need additional fluids but may need rapid medication delivery depending on the situation you have. Access ports commonly used with these patients who have disorders such as heart failure or pulmonary edema. So you're going to attach the end of the IV catheter with a filled, approximately full of 2 mLs of normal saline. Saline remains in the port without entering the vein, preventing clotting at a sealed access site, also known as an intermittent site. This will also eliminate the need to reestablish an IV line each time the patient needs medications. Okay, so these go in, they stay in. They can stay in for 24 to 48 hours, sometimes even longer, depending on if the patient has any infections or any kind of streaking or anything else that is noted. This is an external jugular vein. Nothing that you guys will be accessing as an advanced EMT. This is a paramedic skill in New Hampshire. It provides venous access to the external jugular vein. So what we do is you don't put a tourniquet on or restriction band. Please do not put a restriction band on these patients. All right. We're not there to choke them out. With this, we try to find the external jugular. We go towards the heart with the vein. So tamp it on the vein by placing one finger over the tongue of a tongue depressor on the vein just above the clavicle, causing the vein to fill up. If the vein is difficult to find, place the patient supine to facilitate venous return. Turn their head to the side, and the catheter is inserted midway between the angle of the jaw and the midclavicular line, in the same manner as a normal IV line would be. All right, so troubleshooting. IV therapy, we're going to check the following. IV fluids. If it's not dripping appropriately, look at the fluids, the administration set, the height of your bag. If the bag is below the heart, it's not going to drip. The higher the bag, the faster it drips in, unless you have an IV pump in place. Type of catheter you use. If you have a 22 gauge catheter in, it's not going to flow fast. 20s flow pretty decent. 18s flow a lot faster, right? And also another thing too is make sure you take off the constricting band. That is also a critical fail on your test station as well. Once you've established access and you advance further, you pull the restricting band off. And we'll go over all that on Sunday. Other possible complications as well would be local IV site reactions. Most local reactions require you to discontinue the administration, reestablish IV line at the opposite extremity, and you have to document the event in your narrative. Infiltration will be an escape of fluid into the surrounding tissue, causing a localized area of edema. Some common causes would be your IV line is passed completely through the vein and to the other side, excessive patient movement, tape used to secure the area has become loose or dislodged, or the catheter was started at an angle that is too shallow and has only entered the fascia surrounding the vein itself. All right, so other signs and symptoms include edema at the catheter site, continued IV flow after the occlusion of the vein from the insertion point. A patient complains of tightness and pain around the IV site. If it hurts around the IV site when you're administering fluid, most likely it's infiltrated. It should not hurt. All right. To correct infiltration, discontinue administration, reestablish on the opposite extremity, or at the most proximal location on the same extremity. It means you have to go closer to the heart. So if you did one in the AC and they blew the AC, you really, unless you have one in the bicep, you have to go to the other side. That's why we always start low first. Apply direct pressure over the swollen area to reduce any further swelling or bleeding into the tissue, and avoid wrapping tape around the extremity for direct pressure. All right, so thrombus or thrombophlebitis is inflammation of the vein itself, not usually seen in the emergency pre-hospital patient, but symptoms would include fever, tenderness, red streaking up the associated vein. Hardening of the vein can also occur if the vein has been repeatedly punctured. So you'll notice that too with IV drug users. You'll notice that a lot of them have hardened veins as well. You'll see a lot of track marks. We cannot do IVs through those. Common causes would be location or localized irritation and infection from the non-sterile equipment, prolonged IV therapy, irritating IV solutions, and there are some that can be very irritating. and burn as well. Like magnesium can have a burning effect. A too rapid of an infusion. If redness develops at the IV site with rapidly developing thrombophlebitis, discontinue the infusion and save the equipment for a later analysis. Reestablish a line on the other extremity, and all new equipment in case there was an unforeseen or unseen contaminant, and document the patient's events and response. Other physical blockages or a vein in the catheter. So the flow rate is not sufficient to keep the fluid moving out the catheter tip. And if blood enters the catheter, a clot may also be occluding the flow. Okay, so it's why we make sure to stay flushed at all times, and then we lock the catheter off so the blood doesn't return back in. Some common causes would include a positional IV site, proximity to a valve, patient movement, or if the IV bag nears empty and the blood pressure overcomes the flow and backs up into the line. If you see that, it's okay. Just run a new bag of fluid in, and at that point in time, it just pushes it back in. Right? You want to be careful of the clotting part of it. Once it clots up, sometimes it's hard to free those clots out. Right? So determine whether the IV line should be reestablished. Use a syringe filled with saline to add pressure to that line. Make sure it still flushes. Gently apply pressure to the plunger. Please do not slam that in. All right. If the flow is reestablished, ensure that the line is free and the rate is sufficient that you need to keep it open. All right. So TKO to keep the vein open, or KVO keep very open. If the occlusion does not dislodge, discontinue administration and reestablish an IV at the opposite side. Right. This is a hematoma. So an accumulation of blood in the tissue surrounding an IV site results from a vein perforation or an improper catheter removal that allows blood to accumulate in the surrounding tissue. Blood can be seen rapidly pooling around the IV site, resulting in tenderness and pain. If a hematoma does develop while you are attempting an insertion of a catheter, stop and directly apply direct pressure to help minimize the bleeding. So push it down, apply direct pressure to the site. If a hematoma develops after a successful catheter insertion, right, which can happen, evaluate the flow and the hematoma. If the hematoma appears to be controlled and the flow is not affected, monitor the site, leave this line in place, and utilize that line. If the hematoma develops as a result of removing the IV line, direct pressure with a 4x4 gauze and pad to the site itself, and apply pressure to kind of reduce that swelling. All right, nerve, tendon, and ligament damage. This is why we don't do blind IV sticks and why we don't fish for veins, because this can actually cause damage to the nerves and the tendons and ligaments. It's a result from improper identification of anatomic structures around an IV site. Risk increases with the IV site choice around joints, and the symptoms include sudden severe shooting pain, numbness in the extremity as well. I can tell you from personal experience, I went to a hospital one time, and they had an AEMT student that was there, and I wasn't paying attention. I said, yeah, go ahead, because I mean, I had no problem with students sticking me. That's how you learn, right? And they did an IV on my forearm, or not my forearm, my AC, and they failed to recognize I had tendons there, and they poked through one of my tendons, and I had numbness in my fingertips for about a month and a half, 2 months, because of what they did, because they weren't paying attention, right? So again, pay attention to that kind of stuff, because the tearing of the ligaments, or I'm sorry, tendons in there, and the nerves can cause a lot of damage, and that could have been permanent, right? Thank God it wasn't. So another one here as well is if you have an arterial puncture, by accident you got into an artery, bright red blood is quickly seen, either spurting from the catheter at the needle, where the needle is withdrawn, or backing up into the IV tubing in the IV bag. If this happens, stop IV administration, apply direct pressure to the site with a gauze for at least 15 minutes until all bleeding is controlled, right? It does happen. We've all been there before. We've stuck we thought was in a vein. We advanced in, next you know, we're inside of an artery. If you had ultrasound, you could actually see that a lot of times veins and arteries are right next to each other if you actually look at ultrasound stuff. Pretty interesting things going inside your arms. So systemic complications can develop from reactions or complications associated with IV insertion. and they can be life-threatening. If an IV line is established in a patient in patent, do not remove it. Often minor, but anaphylaxis is also possible. Any allergic reaction must be treated aggressively and can be related to the individual's unexpected sensitivity to a medication that was given. Common signs and symptoms would be itching, shortness of breath, edema to the face and hands, urticaria, bronchospasm, anaphylaxis, and wheezing. If you see this, discontinue the IV administration and remove the solution that's currently going in. Leave the catheter in place as an emergency medication route only and notify med control immediately and maintain an open airway. Monitor ABCs and vital signs and document the event and keep the IV bag or medication for evaluation by the hospital. If you have an air embolus, which are air bubbles that blocks blood flow, properly flushing an IV line will help eliminate any potential introduction of air into the patient. Right? So IV bags are designed to collapse as they empty to help prevent this problem. So be sure to replace empty IV bags with full ones. If your patient begins to experience respiratory distress with unequal breath sounds, consider the possibility of an air embolus. This is dangerous stuff. This can kill people. Right? So signs and symptoms include cyanosis, signs and symptoms of shock, loss of consciousness, and respiratory arrest. So treat the patient with suspected air embolus by placing the patient on their left side with their head down. Rapidly transport to the closest, most appropriate facility, and be prepared to assist ventilations if the patient experiences increasing shortness of breath or inadequate tidal volume, and document the event that happened. If you have a catheter shear, this occurs when part of the catheter is pinched against the needle and the needle slices through the catheter, creating a free-floating segment. The catheter segment then can travel through the circulatory system, and then also blockage of other vessels may result in a myocardial infarction, stroke, or any kind of other problem that may occur. This can possibly end up in a pulmonary circulation, causing a pulmonary embolus as well. So treatment involves surgical removal of the sheared tip. The catheter hubs are radiopaque to aid in diagnosing this type of problem, so they can be picked up on radiology. Never rethread a catheter. So once you've advanced forward, don't put the needle back through again, because that can cause that shear. If you advance forward and it doesn't move, then take the needle out, start with a different catheter. Patients who have experienced catheter shear pulmonary artery occlusion may present with sudden dyspnea, shortness of breath, and the possibility of diminished lung sounds. Treat the same way you would with an air embolus and try to obtain IV line in the other extremity. Right? Circulatory overload. So patients with cardiac or pulmonary or renal dysfunction cannot tolerate any additional demands from increased circulatory volume. So in trauma patients, increased circulatory volume from overaggressive resuscitation can disrupt clot formation and increase ongoing hemorrhage. Right? That's what I talked about before. Trauma scenarios, we want to make sure we're keeping our blood pressures around 90 systolic. We don't want to have increased flow or increasing blood pressures, because that can cause more damage. The most common cause of circulatory overload is the failure to readjust the drip rate after flushing an IV line and immediately after insertion. Right? So know how much fluid you want to give. What is your goal? Always monitor IV bags to ensure the proper drip rate and ensure the presentation, patient presentation, make sure it includes dyspnea, jugular vein dissension, or increased blood pressure. We want to make sure we turn that stuff down. Crackles are often heard when evaluating breath sounds. Every 500 mLs that go into a patient, you should be slowing down the drip, taking a listen to lung sounds, and if we hear fluids or they have shortness of breath, turn the fluids off. We can't just pump in 1,000 mLs of fluid at a time over 5-minute periods, right, without having to do an assessment halfway through. Right? If you start seeing potential for acute peripheral edema, it can also be an indication. Slow the IV rate down, and keep the vein open only. Right? And then raise the patient's head to ease respiratory distress. And also give them oxygen as well and monitor vital signs. You may also have vasovagal reactions as well. Some patients have anxiety concerning needles or the sight of blood. This may cause a vasculature dilation, resulting in a decrease in blood pressure and the patient collapse. So signs would include anxiety, diaphoresis, nausea, syncopal episodes as well. Treatment for a patient is placed position and dictated by protocol for shock management, position of comfort, give them high flow oxygen, and monitor vitals every 5 minutes, and establish an IV line in case a fluid resuscitation is needed. Okay, this could happen. As far as pediatric IV therapy considerations, right, if a pediatric needs an IV, put one in. Please do not be scared that they're kids. Right, I'll teach you some different techniques in the next slide here too, and we'll talk more about them as well. But looking at the different size catheters, we have 20, 22, 24. We do not have 26 gauge catheters. Okay, we have 24 is the smallest one that we go. Depends on the best insertion for the patient. Depending on the size of the patient and the size of the available veins that you can find. Butterfly catheters are ideal. The problem with butterfly catheters, it's hard to do fluid administration through those. But scalp veins are the best used in young infants. 24 is the smallest catheter we run into. It's a yellow top. We have yellow, blue, pink, green, gray, and orange being the 14 gauge. These are all slide catheters as well that you see on the screen. As far as IV locations go, the younger the pediatric patient, the fewer choices you really have for IV sites. Hand veins are painful and difficult to manage, but remain the location of choice for pre-hospital or peripheral IV line. The best ones usually are just before the wrist or the foot for pediatrics. So protecting the IV site after it has been established is critical. Use a pen light to illuminate veins on the back of the hand. Or scalp veins, also cannulation is often unpleasant for both the child and the parents. However, if it's needed and it's accessed, we do it. So when you are securing a scalp vein, tape a paper cup over the site to avoid applying any direct pressure to the butterfly catheter on the head. All right, I have not done many scalp veins. Usually we can get them in the hands. Depending on age, you can also find ACs, but forearms are very hard to get on pediatrics. And the more difficult ones, I've had to use guided ultrasound to actually get the IV sites. As far as geriatric IV therapy, smaller catheters may be preferred unless rapid fluid replacement is needed. Some medications used by older adults have the tendency to create fragile skin and veins. So a lot of times also with this, they roll. So good stabilization. Try not, if you have a fragile vein, have them pull the ambulance over and then do a line when you're not moving. Often a simple puncture of the vein can cause a massive hematoma, especially if they're on blood thinners. Use of tape can also result in skin damage. And we do use a lot of tape to tape these things down. So be careful. Use smaller catheters from 24 to 20 gauge catheters, which are more comfortable, right? And reduce the risk of, reduce the risk of being removed or falling out or patients being caught. IV sets, be careful when using a macro set because this will lead to edema if not monitored closely. Micro sets are there. Yeah, we call them pediatric drip sets, but they can be used for adults. Okay, it doesn't give as much fluid as fast, but you're still going to deliver the same amount of volume. This may not be the faster rate. Fluid overloading is potentially serious in geriatrics and pediatric patients, so you have to monitor them closely. All right, so as far as locations and choosing an IV site, consider the possibility of poor vein elasticity. As you can see on the back here, the back of the wrist, you do have some veins. You can see my mouse moving here. There's one that runs here and one that runs here, right? Do you see the bumps that I'm highlighting over now? Can you guys see that? The mouse right there.
Yeah.
Okay, those are valves. Okay, that's a problem with those. Okay, so if you start an IV access point here and you go down this direction, there's a valve right there that you may not be able to pass the catheter through, and you may blow the vein or can't pass it through the valve itself, right? So take a look closely at your veins as you look through and see if they're valvy or not. If they're full of valves, then we can't go there. We got to find another spot. So Mike, I'm glad I just saw your post. So isn't the protocol for stroke no less than 18 gauge in the left AC? It might be the right. So that is protocol for 18. Okay. The reason why they put an 18 gauge in is they do something called a CTA. Okay, which is a angio, CT angiogram, where they inject dye at a certain rate. Okay, the 20 gauge catheters normally cannot handle that fast of a push if it is located like in the wrist or the forearm, which is why they want it up in the ACs. And the reason why they picked the right side is because that's where and you probably already know this because you put down angio on here. That's where the chemicals that get pushed through the dye gets pushed on the right side. That's why they recommend them. 18s are recommended for stroke, but if you can't sink an 18, you get a 20. That works perfectly fine. They do make catheters, and I'm drawing a blank of the name, and I can't remember why. Nexiva, that's it. So Nexiva makes a catheter, which is a longer needle that can take a higher pressure at the 20 gauge. So it has multiple ports at the very end versus one. That makes it to the point where you can't blow the line. But good point. I'm glad you brought that up though as well for stroke patients. They recommend 18 gauges on the right side. I usually put bilateral lines in for any patient that has a stroke or cardiac event. That's why I get 2 lines in place. But good job, Mike. Thanks for bringing that up. Aging causes a loss of elasticity in the body tissues. Okay, so avoid small spidery veins that are weak, that weave back and forth, because you're probably not going to sink a line in those, as you can see on these right here. And also there as well. And do not use varicose veins as they allow minimal circulation. So don't stick those. And if you break one open, one hell of a mess. All right. Any questions so far? Good so far?
I think you, when you passed by it, I didn't catch it, but I didn't want to interrupt you. You said no EJs for us, right? That's on the medic scale?
Correct.
All right, perfect.
Yeah, I'd have to look at Mass Protocol London for that. I don't remember off the top of my head, but I'm pretty sure you can't. They wouldn't let you do cardiac monitoring. So I'm pretty sure EJs are out.
Yeah, it's weird because I've been kind of looking over that. So yeah, they'll let you throw lines and drill people to do whatever. But yeah, EJs,
Right.
monitors, and even some of the glucagon and stuff like that, they're a little weird about it. So
Yeah. All right. So as far as interosseous, this goes into the bone. So having an idea. So again, I have some interosseous bones. You guys will be doing some drilling on fake patients, not real patients or students, on Sunday. Sorry about that. No one can drill each other. But I do have bones you can practice drilling on. So a technique of administering fluids. It's no different from interosseous to intravenous. It gets into the vascular just as fast. The only difference is you got to put pressure bags on your IO infusions, right? And then one of the things that's within the scope of practice for New Hampshire providers, you can actually do IOs on conscious patients. And you do have the ability to give lidocaine, cardiac lidocaine, to a patient after you've drilled to numb the site. So as we're drilling in, okay, we look for the tibial tuberosity and find the tibial plateau. Excuse me, and then we drill on that location there. The needle comes in, goes into the spongy bone, right? Where this is very, very hard outside layer. Because of that, it's not like a vein that has elasticity to it. This is solid. So pushing fluid through here can actually cause significant pain, all right, on a patient who's awake. The way we look at it is you get 2 attempts or 90 seconds on any critical patient. 2 attempts, 90 seconds. There are 6 locations that you can do an IO, and that's the proximal and distal tibia, and then the humeral head on each side of the shoulder. So we have 6 different locations. So long bones consist of the shaft and the ends, and then the growth plates, epithelial plates, diaphysis, epiphysis. The IO space comprises the spongy cancellous bone of the epiphysis and the medullary cavity on the diaphysis, as you saw in the previous picture. The IO space is commonly referred to as the non-collapsible vein. Anything that can be given IV can be given IO. An IO infusion is indicated when you are unable to rapidly obtain IV access on a critically ill or injured patients. Vascular access times and flow rates for various IO sites are presented in table 13.2 in your books, right? So here's the thing. 2 attempts, 90 seconds on a critical patient. If you can't find anything within 90 seconds and the patient's going to die, you drill them. I don't care if it's going to hurt them or not. It's life-saving, right? Drill the patient. In the next slide here, you're going to see the humeral head being drilled in the shoulder. Very hard to miss this. The only drawback with the humeral IO site is that the movement of the shoulder can actually displace it. But the humeral head is such a big opening, you can move it in every different angle. You also want to make sure that you use a large adult needle for those because of the size of the space it needs to go into. This humeral head has a direct contact with a subclavian vein that runs down through here, and it's like a central line to the heart. They recommend this as the site for all IO interosseous, especially in cardiac arrest. However, doing this up here with mechanical CPR can dislodge it. You're also pushing meds next to the person securing airway, next to the person that's doing cardiac monitoring, and you're kind of in the way. That's why everybody usually goes to the proximal tibia for it. Another one here also is what they call a sternal IO. So identify the sternal IO by palpating the sternal notch and use the IO device as an adhesive target, and then you can drill in. Now again, we're not doing sternal IOs in New Hampshire. It's not in Maine as of right now. The sternal IO site also has an extremely rapid flow rate as well, which also helps. So to locate the proximal tibia, palpate the tibial tuberosity, then palpate 2 centimeters medially, and you'll find a tibial plateau. For the distal tibia site, identify the medial malleolus and palpate 2 to 3 centimeters above it. That's your drilling point down below. So technically you have 6 different access points for IO insertion. Please do not put 6 IOs into a patient, all right? I've seen 2, really don't need to go more than that. Once you get one to get enough fluids in and patient's more stabilized, try looking for another IV site. Once you start getting fluids, the veins may actually start popping out better. These are called Jamshidi needles. These are a manual IO insertion, okay? We are not using these anymore. Everything's gone to easy IO. But there's different ones. New interosseous NIO device. There's a bone injection gun, or the BIG, or the BIG. The fast one, you have manually inserted. The most common one that we're seeing out there right now is easy IO. So use of these devices requires specialized training throughout familiarity and then the features. You have to be trained on the device you have. Right? I can't train you on all of them, but I can train you on the ones that I currently carry. And then at your service, you have to go through specific IO training. Equipment for this is fast devices. So first IO device approved for the patients ages 12 years and older. There are 4 design elements of IO placement in the sternum using the fast device: an infusion tube, an introducer, a target strain patch relief patch, and a protective dome. This can be used during cardiac arrest. This is a fast here. I have never used one of these before, right? So anybody that has had experience with these, feel free to share on Sunday. The next one is going to be the Easy IO, which is the most common one that we see. The handheld battery powered device. You cannot change the batteries out in these. Once the battery is dead, you buy a new gun. IO needles for these are fairly expensive, about $80 a needle or so. You can put them in the proximal distal tibia on children and adult, and then adults only in the humeral head. We'll go over all this on Sunday. The bone injection gun. It's more Mike, so it's age. But the thing is, though, is the Easy IO is used for anything from pediatrics all the way up, and even neonates as well. They actually recommend doing IOs on neonates if you can't find a line. So. All right. Good question, though. Good question. The BIG, bone injection gun, is a spring-loaded device that is used to insert an IO needle into the proximal tibia of the adult and pediatric patient. Literally, it's under a spring, and it pops into place. This is the new intraosseous device, the NIO, spring-loaded, placed in the proximal tibia. There's all different types that are out there. I personally like the Easy IO drill. A service I work for in Maine just got a handheld one that's literally, you squeeze it like the old VVAC suctions and it drills into the bone. No batteries required at all. So there are all different ones that are out there now. All right, so performing an IO infusion. Again, follow the steps and the skill drills for IO infusion. We will cover all this stuff here more in depth on Sunday. Position yourself behind the patient's head. Place 2 hands on the fast device, as you can see here. Align the stabilization needles from the target. Apply pressure until you feel the infusion tube separate from the fast introducer. You just push down until you feel it. We're going to discard the stabilization needles into a sharps container and attach IV tubing to the insertion tube luer lock. Most of the time they come with one built into the package. You want to make sure you pull back first and aspirate blood or bone marrow to ensure proper placement. If you don't see it, then you're probably not in the right spot. Slowly inject IV solution to ensure a proper placement of the needle. And then also at that point in time, we're going to adjust the flow rate as appropriate. You're probably going to need a pressure bag. If you don't have a pressure bag, you can use a BP cuff around the bag and inflate the BP cuff to be able to push fluids through. Some other complications, obviously, if used properly, IO infusion is associated with a relatively low complication rate. All right, so potential complications associated with IV therapy can also occur with IO infusion. If you miss it, goes through it, you can have inflammation. You can also have fluid buildup around that site as well. So you want to make sure your osteomyelitis is inflation of the bone and the muscles caused by an infection. So you want to be careful when you do these, but when they're in, keep an eye out of the site. Make sure you're not seeing the knee or whatnot ballooning up. That means that you have fluid going out into the spaces. Failure to identify the proper anatomic landmark can result in long-term bone growth abnormalities in children, because then we're drilling into the bone, the growth plates. Fractures can also occur if your insertion technique is too forceful, or use an IO needle that is too large for the patient's age or size. So through and through insertions occur when IO needles passes through both sides of the bone, and it's suspected pulmonary embolus if the patient experiences acute shortness of breath, pleuritic chest pain, and cyanosis. All right, contraindications obviously would be a fracture of the bone intended for the IO cannulation, osteoporosis, osteogenesis imperfecta, bilateral knee replacements, or prosthetic limbs. Probably don't want to drill into a piece of plastic, right? So palpate, look, feel, make sure it's not replaced. Look for the scars for knee replacements, things like that. All right. Why don't we, it's been going for another hour again. Let's take 10 minutes. We'll come back at 8:27. And we'll move on with med math. We'll finish up with this slide and we'll start the next one.
This conference will now be recorded.
All right, so we're going to talk about mathematical principles used in pharmacology. All right. So basic mathematical principles to calculate accurate medication dose. This is very important so we don't give the wrong amount of medication, right? So a little review. Fractions are expressed as a number, so portion available over the denominator total quantity. Decimals distinguish numbers greater than 0 from numbers smaller than 0. For example, nitroglycerin being 0.4 milligrams, which would also be equivalent to, we'll get more to that actually, it's not to jump ahead. All right, whole numbers appear to the left side of the decimal where the fraction of the number appears to the right. Fractions can easily be converted to decimal by dividing the numerator, by the denominator. So example would be 1/2 of 1 milligram would be 1 divided by 2, which would be 0.5. The things we do at the advanced level are very simple med math. We're not going to get into anything extravagant. All right, when dividing or multiplying a 10 by 10, remember that the following method. If dividing a number by 10, move the decimal point to the left. If multiplying a number by 10, move the decimal point to the right. Example, 20 times 10. Decimal point, place the decimal point 20.0. To multiply by 10, move the decimal point 1 space to the right, which would make it 200.0. It's very important. Anything we do with mathematical equations and dosaging, that we always have a number on either side of the decimal, okay? Percentages are part of 100 and are denoted by percent symbol. This can be represented as a fraction with the denominator being 100. Decimals can also be turned into percentages easily by moving the decimal point 2 places to the right. We can go over some simple med math on Sunday as well for conversions. So the metric system, because we can't confuse anything else, now we're adding a metric system into this as well. So the decimal system, based on multiples of 10, are used to measure length, volume, and weight, as in meters, basic unit for length, liters for volume, and grams for weight. So the prefixes demonstrate the fraction of the base being used. For example, commonly used prefixes from smallest to largest include the following: micro, milli, centi, kilo. So as you can see, 1,000 kilograms is equal to 0.01 centigrams versus milligrams and micrograms. What we use a lot of is micrograms and milligrams in the field. Right, those are the two that we're going to use a lot as far as medication dosaging. I'm just trying to think of everything that you guys give at the A level. I don't think there's anything at the advanced level that's micrograms. That would be more towards the paramedics, like fentanyl is given in micrograms. Milligrams would be 90% of the stuff. Kilograms you need to know based on weight to convert. But everything that we do pre-hospitally for the advanced level will be milliliters, liters, and then milligrams and grams. Grams being your oral glucose tubes are done in grams. All right. So volume conversion is 1 liter equals 1,000 milliliters. So with this here, we want to do weight conversion. So to convert grams to milligrams, multiply by 1,000 or move the decimal point over 3 places to the left. To convert milligrams to grams, divide by 1,000 or move the decimal point 3 places to the right. So it's actually fairly simple when you're trying to convert liters to milliliters. Like I said, we'll do when we start playing with medications and you can actually see it in front of you. It makes more sense than me describing it over virtual lectures. So converting pounds to kilograms, divide the patient's weight by 2.2 or divide the patient's weight in pounds by 2 and subtract 10%. So like I mentioned before, the patient weighs 100 pounds, divide that by 2 is 50, and 10% is the first number, 5, so it'd be 45 kilos. If the patient weighs 300 pounds, right, divide that by 2 is 150, then you subtract 15 because of the 3-digit number, you take out the first 2, which would be 135 kilograms. Does that make sense to everybody?
Yes.
Okay. The other option is use your phone divided by 2.2. But if your phone is dead, you have to have an understanding of how to do a quick math. Now, if it's going down to a decimal point, always round up, not down. Don't underdose anybody. You can overdose someone a little bit, it's not going to hurt them. Where things become more precise is when you start dealing with pediatrics, right? If you do 30 mLs per kilo for a patient getting fluid administration, you happen to give them 10 mLs more, it's not going to hurt the patient. But with pediatrics and neonates, 10 mLs is a lot, right? That's not something you want to mess up, especially when you start getting into critical care medicine, where you have to keep in mind the amount of narcotics you're giving and everything else. Everything is based on total amount of volume they can receive in a 24-hour period. So everything is calculated, including the medicine even going into the patient on top of fluids, right? So pediatrics, very critical to make sure you have the weight exact and all your numbers exact versus adult, where if it's fluids, a little bit's not going to hurt them, okay? But medicine might, okay? So you got to make sure you're getting precise dosaging as well to your best ability. All right, so calculating drip rates. When you administer IV fluids, you'll need to calculate the drip rate that's there. We don't have the ability to use IV pumps, not at the advanced level. One of the easiest ways to calculate the drip rate is to use dimensional analysis. Dimensional analysis allows you to compare seemingly unrelated items by setting up a relationship and using ratios as conversion factors. All right, so to calculate a drip rate, you need to know which administration set you are using. Is it a 15 drop set or is it a 60 drop set? The length of time for the infusion, how long do you want it to go in for? 15 minutes, 20 minutes, 1 hour? 1 hour would actually be 60 minutes, 2 hours would actually be 120 minutes. You got to break that stuff down. And the amount of flow, how much do we want to give, right? So in order to, so an example would be, and if you guys have paper in front of you, if you do, you can write this stuff out if you're driving or on the road. Please don't do it while you're driving. All right. The order is given for 250 mLs of normal saline over 90 minutes. The administration set is 5 macro drip, okay, which is 10 drops per ml. To determine how many drops per minute you should be given, you have to do drops by minute equals 10 drops divided by 1 ml, or over 1 ml, sorry, times 250 mLs over 90 minutes. Cancel out what you can, ml, and reduce the fractions down. So instead of 10 over 1, it'd be 1 over 1. And then instead of 250 over 90, it'd be 250 over 9. Okay? Again, this probably makes more sense if you saw it on paper. I'm just trying to read out the equation. Multiply and divide, right? So we take 250 over 9 would equal 2.77 drops per ml. That would be 28 drops. So you have to count those out. You have to have 28 drops, right, per ml of fluid to be given. It will make more sense on Sunday when I actually go over it with you. So I do apologize. It's hard to do this in a non-classroom setting. All right. So if I say, does anybody have any questions? I'm sure a lot of people will say, yes, I do, right? I need to actually show you in person. Very hard to do over this. Right. So excuse me, we'll go over more of how this works in fluid administration once we get there on Sunday. All right. So with this here, calculating the medication dose, there are multiple formulas of calculating medication dosing. Right? The method of drug dose calculation demonstrated here is based on the following three factors. 1, desired dose we want to give. 2, the concentration of the medication available, dose on hand. And 3, volume to be administered. Okay? And again, I have vials of medication you guys can do med math on Sunday. I have a whole bunch of different ones. Yeah, some of them are paramedic meds. It doesn't matter. It's still med math. The desired dose is the amount of medication the physician orders you to administer to a patient. This may be expressed as a standard dose or a specific number of grams or milligrams per kilogram of body weights. The medication concentration is the total amount of medication contained in a specific volume. So note that the medications are contained in different volumes of solution. This is your volume at hand. So one example would be is ketamine is supplied to us as 500 milligrams in 10 mLs, okay? So if you break that down, how many milligrams per ml would that be?
50?
50, exactly, right? 50 milligrams. And then I tell you the amount ordered is going to be, let's say 40 milligrams need to be ordered. So how many mLs do you give? It's 50 milligrams per ml, and I tell you I want you to give 40 milligrams of ketamine intramuscular. How many mLs need to be administered? Yep, 0.8, exactly. So you got to break that down, okay? So it'd be 5 milligrams per 0.1 ml. So there may be medications you need to break down to that level as you're administering, okay? Now, are there apps out there to help you? Absolutely there are. At 3 o'clock in the morning, it's going to be very difficult at times if you're not proficient with med math, right, to figure stuff out. So use a calculator, okay? It definitely helps you. But you got to break things down to what you want to give. Okay, that goes back to desired dose, concentration, and volume to be administered. My desired dose is 40 milligrams. My concentration is 550. It's for 510. So I have to give 0.8 mLs to meet my desired dose of 40 milligrams. Does that make sense?
Yes.
Okay. Again, the best thing to do is look at different vials of meds when you're on shift somewhere and break it down. I want to give this, okay? There's nothing wrong with asking other medics at your service. This is not outside of your realm for clinical rotations because you're not doing anything. You're just writing stuff down on paper. Be proficient with med math. Look at your protocols. Zofran on Dancitron is a medication you can administer. It comes in 4 milligrams per 2 mLs. If I told you you had to give 2 milligrams of Zofran to a patient, how many mLs would you give?
1 ml?
One.
Yeah, one. Simple, right? So that's how things work with that. So if I said to you, here's another one for you, right? I got a pediatric patient in hypovolemic shock. The pediatric weighs 50 pounds, okay? 50-pound patient, and you have to give your equation of 20 mLs per kilo.
Me too.
So how would we figure that out? 50-pound patient, 20 mLs per kilo. I got to administer how much fluid? Right? So if I take 50 pounds divided by 2 is 25, minus 2 is 23. To do 23 times 20 is how much?
460.
23 times 20. Okay.
Yeah, 400.
Yeah, I'm seeing 460. And that's how much fluid we're going to administer to that patient. Okay. So now I want to administer 460 mLs. Now I got to break that down by drip. Okay. And I want to know how many drops per minute I want to be giving. Or you can do a measured dose. Okay. A measured dose with that as well by just drawing it up into a syringe, administering syringe boluses to this patient. Or you can use a butyrol set and put 460 mLs into a butyrol set and drip that in precisely. But if you're using a straight bag, that's not precise medication administration. So you gotta know how many drips it's gonna take per ml. So now that we know this, okay, a 15 drop set is 15 drops per ml, okay, of fluid to fill the chamber, 15 drops per ml. So you can do the math and figure out how many drops you need to administer for fluid. You can break that stuff down. And that's how we have to do med math. Now, can a paramedic cheat on this? Yeah, they can put it into a pump, right? But I'm not going to use a pump to administer this stuff. I'm going to do the math out, figure out how many drips it's going to be, and administer the stuff. The problem with that is you got to be very precise, right? On top of that, because you don't want to give too much. This is why butyrol sets were created. This is why you have syringes to be able to push the fluids, so you don't over medicate a patient. But I just gave you scenarios. So look in your book. In your book, you'll have different scenarios you can utilize and break things down. So that's what you have to know off the top of your head, especially at 3 o'clock in the morning when you got a kid who took a fall that has an internal bleed and you got to replace some fluid at 20 mLs per kilo. 30 mLs per kilo for adults, 20 for pediatric, 10 for neonates. All right. So volume to be administered is the volume to be administered equals the desired dose in milligrams divided by the concentration at current hand. We've kind of already covered this. Ensure the units in the desired dose match the units in the top of the concentration on hand fraction. So you would be ordered to administer 12.5 grams of dextrose to a hypoglycemic patient. You have a pre-filled syringe of 25 grams of D50 and 250 mLs. Okay. So if I want you to give 12.5 grams of dextrose and you're supplied 25 grams of D50 and 50 mLs, how many mLs do you give?
What was the question?
So if I ordered you to give 12.5 grams of dextrose to a hypoglycemic patient, your supply comes in 25 grams of D50 and 50 mLs. How many mLs do you give? Everybody can do math a little bit differently. So you can break it down to determine the concentration dose at hand in grams per ml. 25 grams divided by 50 mLs is 0.5 grams per ml dose on hand, right? And I want you to give 12.5. So you would take the determine how much this volume is administered, which is 12.5 grams desired dose, divide that by 0.5 grams per ml dose on hand equals 25 milliliters. That seems like a lot, pretty simple. So, I mean, it's actually fairly simple. 25 divided by 2 is 12.5. 50 divided by 2 is 25, is 25 mLs. Right? There's other methods and ways you can work around it as long as it all comes down to the same answer. Remember that pediatric doses are all weight-based, so you can also use a resuscitation tape Those give you a lot of the answers for you. The Broslo tapes that are on there as well. There's the field guides tables. I use an app called PDStat, which is phenomenal. I think it's like $5, but definitely worth it. You put in the patient's weight and you open it up, and everything you do in that app from that point on is based on the actual patient's size. So it's called PDStat, PEDISTAT. That's what it's called there to everybody. I love that app. It's phenomenal. All right, almost there. So steps for administering specific routes. So obviously administering internal medication given through some portion of the digestive or internal intestinal tract include medications that are oral, which we do have in the field. PO Tylenol, Zofran is given oral as well. ODT Zofran, oral dissolving tablet. Motrin, ibuprofen. Rectally for like Diastat. Oral medications like capsules, time-release capsules, lozenges, pills, tablets, elixirs, emulsions, suspensions, syrups, all different types that are there. Used when desired effect is systemic, and medications are taken up by the intestines, all different ones that are located there. To give oral medications, you may use small medicine cups or medicine droppers, teaspoons, oral syringes, or a nipple of some sort. With that being said, we do carry liquid Tylenol as well for pediatrics. So you may have to do that, draw it up in a syringe and administer it through a syringe. When administering an oral medication, take standard precautions, determine the need for the medication, and obtain history, including medications and allergies. Last thing you want is give something they're allergic to. Follow standing orders and contact medical control for permission, and check the medication to make sure it's the right. Make sure you're following the rights of patient administration. If administering a pill or a tablet, instruct the patient to swallow the medication with water. Every ambulance should be carrying water. Monitor the patient's condition, document the med, route, time, administration, and patient's response and your reassessment. For rectal administration, if rectal administration of D50 is allowed, it should only be used as a last resort. We are not giving that rectal. However, you can, as an AEMT, even as an EMT, assist with rectal Diastat or Valium for pediatric seizures if the parents have it there. All right. Highly absorbing area. Takes it in very, very well. Right. But in our protocols, rectal D50 is not within our scope of practice. All right. To administer a drug rectally, use standard precautions, determine the need, obtain the history, follow standing orders, determine the appropriate dose, and check the medication is the right medication for the patient, and there is no cloudiness or discoloration, and expiration date has not passed. When inserting a suppository, use a water-soluble gel for lubricant. Insert the suppository into the rectum approximately 1 to 1.5 inches while instructing the patient to relax and not bear down. If they bear down, it tightens up the sphincter and it pushes it back out again. For medications that are liquid form, some modifications are needed. You may need to use a nasopharyngeal airway or a smaller endotracheal tube or an 18-gauge IV catheter without the needle, or a commercial device as your delivery device. Lubricate the end, put it in the rectum, 1 to 1.5 inches, and have not bear down with a needleless syringe. Gently push the medication through the tube. Administering parenteral would be subcutaneous, IM, IV bolus, IO, sublingual, transcutaneous, transdermal, inhalation. Let's go over those really quick. So for administration, subcutaneous, sorry, I'm a little too fast there. Subcutaneous would be just under the skin layer into the subcutaneous tissue, administering a medication. Intramuscular, we find a muscle, whether it be lateral thighs, buttocks, deltoids. Obviously, IV bolus is intravenous, IO is interosseous. Sublingual being under the tongue, transcutaneous through the skin, or transdermal. And then inhalation, obviously, would be like our albuterol, things like that. More of your transdermal medications are going to be like your nitro paste that you would have available. And some states allow AEMTs use nitro-based for acute pulmonary edema. IV administration is the most common parenteral medication route in the pre-hospital setting, which we've already talked about quite a bit in IV therapy. Syringes come pre-packed in color-coded packs with needle already attached. Some do, some do not. So as you can see, this is a plunger here. This is the barrel, the flange, right, and the tip being down here. This needs to make sure it's kept sterile, so always leave a cap on it until you need it. They come in many different sizes, from 1 ml up to 100 mLs. So choose the size that you need appropriate. We'll go over all this kind of stuff on Sunday for medication administration. Ampules, another way, usually epinephrine are packed. I will show you guys the proper way to break those as well. Vials contain a single or a multiple dose, depending on the size vial, and it will tell you for multiple dose usage. They can be made of plastic and or glass. These are usually made of glass, and they have to break off here. So you have to have a proper technique to get the air and fluid separated, and then have a technique to break off these here. And anytime you use a glass ampule, you have to use a filter needle to pull the medication out, so you don't get shards of glass into your syringe and push that into somebody's vein. We'll cover all that, like I said, all this on Sunday. These are pre-filled syringes. Your epinephrine are usually kept this way. Other than that, lately with epi shortages, we have to make our own. All right. So as far as vials go, these are like more like Solumedrol, Solu-Cortef. You'll find in these type here. There's a plunger in the middle. You take this orange top, you push it down. It then takes the air and fluid that's inside of here and pushes the plunger in. You mix up the powder with, or the medicine with the fluid, and then you tip it over. You pop off the orange top on a small little cover on the top here. You pull back air first, inject the needle into it, push the air into the vial, and you can draw back your fluids. Again, all stuff that we're going to practice on Sunday. These are pre-filled syringes. These are your epinephrine or atropine. These are all pre-filled. Your D50 is usually like this as well. They come in a tamper-proof box. You pop off the yellow tops like Johnny and Roy. For those of you who know who that is. You screw these two together, and then you administer the medication. With subcutaneous, as you can see here, 45-degree angle in, into the subcutaneous tissue. Please do not put it into the muscle. Then you administer the medicine. There's really nothing we're going to give subcutaneous as an AEMT. And they talk about epi, we're doing that intramuscular. So this is performed with a 24 to 26 gauge half-inch catheter. Some common sites, obviously your upper arm, part of the arms for subcutaneous, the abdomen, thighs that we can utilize. This is the most common here is in the abdomen. And you want to use an aseptic technique as well. Make sure you clean everything, starting in the middle and working your way out like I'm doing with the arrow here, and bigger and bigger. All right, so IM injections are made by penetrating the needle through the dermis and subcutaneous tissue into the muscle. This goes in at a 90-degree angle in. Pinch the skin prior to, stick the needle in, and then administer the medication. Draw back a little bit too to make sure you don't have any blood coming through. Make sure you're not into a vein. That would be horrible if you did that. And administer that medicine in. The drawback for this, it does take a little bit longer to kick in, being intramuscular versus intravenous being the fastest. So as you pull this needle back out, dispose of it, and put your hand over the site and rub the muscle. It helps disperse the medication better. Excuse me, also reduce a lot of the pain as well. You want to make sure you choose an appropriate site. So common anatomic sites with IM injections would be the deltoid, the vastus and lataris muscle, so obviously the outside, lateral thigh, rectus femoris muscle, and the gluteal area. Sublingual medication would be underneath the tongue. You guys should be very familiar with that already because you have EMTs that can assist with nitro. Medications come in tablet, liquid, or spray forms. Intranasal medication, obviously using a nasal atomizer, aerosolizes the medication into the nose. We stick it in each nostril that we administer. Right now, the medication we utilize the most for this one here would be Narcan, prior to IM or IV as well. These are your MDIs, your meter dose inhalers. Again, this is also a EMT skill, scope of practice, so this should be all review for you. If you have a spacer, what we do is we spray it into the spacer, and then we have the patient inhale that's inside here. You want to have them exhale everything out, then deep breath in. You want to have them hold their breath for at least 10 seconds if they can. That way they get the medication deep into the lungs. All this is a rescue inhaler. The better route would be utilizing a liquid bronchodilator, whether it be albuterol or a duoneb, put into this chamber. This will run at 6 liters per minute. What they'll do is they'll put their lips over here and they'll suck in that medication into their lungs. It's what they call a small volume nebulizer. They also make other methods of utilizing a mask for this as well, that has a chamber like this underneath the mask, into a mask. Other options you can utilize for this would be a non-rebreather. Just pull the rebreather mask off, and you can stick the nebulizer chamber up inside of it. Patients that are weak and need this medication probably can't hold this up to their own lips, so putting it into a mask form will actually help them a lot better. Right? As you can see down here, this is utilizing CPAP, and you can see the small volume nebulizer hooked into the CPAP device. This turning knob on top increases your PEEP from 5 to 7.5 to 10, and some go up to 15 now based on new protocols. Intravenous medication places medication directly into the circulatory system, which is the fastest route of medication administration. Keep in mind that there is no room for error. If you push it, you can't take it back. Right? Does that make sense, everybody? If you push the medication into a vein, you can't take it back. Okay. So make sure you understand what you are putting in. Triple check your vial before you administer something, so you do not give the wrong med. Okay, that would be detrimental. In a Dear Chief letter. Many services now use needleless systems to provide protection against needle sticks. There are still some out there that still have needles present, which we still have needle ports available. A bolus is a single dose given by an IV route. Okay, single dose given. Complications may arise from using the IV route, including local and systemic problems. So you want to make sure that you're always monitoring your IV site and also vital signs as you go. All right. Steps to administer intravenous meds. Follow the skill drills in skill drill 1312 when administering medication by IV bolus. So follow these steps. 1, take standard precautions. Wear your gloves, mask, eye protection. Determine the need for medication based on the patient presentation. Obtain a history, including any medication allergies and vital signs. Follow standing orders or contact med control for permission. Check the rights of the medication administration, including ensuring that the medication is not cloudy or discolored and that the expiration date has not passed. If it's expired, please do not give it to the patient unless the pharmacy has a label on that medication stating that it's okay to do so. Okay? Explain the procedure to the patient and the need for medication. Know your ins and outs of these meds because you need to explain to them the side effects. Assemble needed equipment, drop the medication, drop the 20 mLs of normal saline to use as a flush for the medication. Cleanse the site port with alcohol or remove the protective cap if it's a needleless system. Always clean the site before you administer. Okay? Get in the habit, once you're an advanced EMT, to keep alcohol preps in your pockets, readily available. Because you always want to make sure you clean your site. Pull back slightly on the syringe plumber to observe the blood return to make sure it's a patent line. Clean the port and insert the needle with the syringe containing the flush. Flush the saline lock and then place the needle in a sharps container. Once you have flushed it with your once you have pushed the medication, flush behind it with that 20 ml flush or 10 ml flush. Push the medication through the lock. That way, we don't lose any medication still sitting in there. All right, like Zofran, if you push it and don't push fluid behind it, 2 milligrams of that Zofran is still going to be sitting in an IV lock, and they're not going to be able to get it. So, and sometimes with medications, if given together, can have a nasty reaction. One of them being sodium bicarb and calcium chloride. If you ever mix those two in an IV line together, it actually starts crystallizing, which is not good. That can do a lot. That can kill a patient. All right. So interosseous medication, the same thing. It's all done the same way, except now we're pushing it into the bone instead. So I want to go through that. That is a National Registry skill station for you guys. So we will be breaking those down as well. All right. That is it for that presentation. Let me just stop the recording here.